today to the Advanced MD and Metagain webinar, the 6 key financial metrics for 2015. We will be providing a recording of this webinar, ebook that has examples of the slides you'll be seeing, plus a bonus ebook about 6 tips on how to build a data disaster recovery program. So, your panelists for today's session, we have Eric Beyer, who's a doctor and an MBA, the Chief Medical Officer of Metagain. We have Derek Griffin, who is a District Manager for Advanced MD. We have Robert Romero, the Vice President of Business Development for Metagain. And I am your host and moderator today. I'm Clint Hughes. I'm the VP of Marketing for Metagain. So, first presenter today will be Dr. Eric Beyer. As I said, he's our Chief Medical Officer. He was an emergency room physician. He went back and got his MBA. He's also been a certified coder. So being able to give you a holistic view of your practice and the business of your practice, a good person to do that is Eric Beyer, our Chief Medical Officer. So Eric, take it away.
Thanks very much, Clint, and welcome everyone to today's webinar. So the current healthcare environment is very challenging in many ways, with ongoing reimbursement cuts by payers, ongoing consolidation of physician groups and hospitals, and a number of uncertainties related to the Affordable Care Act. To address and overcome these challenges, it's very important for medical practices to monitor and manage key metrics that drive the financial performance of the practice. So the purpose of today's webinar is to share some of the key metrics and information that we have found will promote improved financial performance in medical practices. So the first slide is, what is your plan for success? It's been said that if you don't know where you're going, any road will take you there. In my experience, many medical practices really don't spend enough time to develop a clear plan of how they will achieve their financial and practice goals. Under the Affordable Care Act, the healthcare environment is moving from one of fee-for-service to one of fee-for-value. As a result, physician groups need to develop a plan with clear goals and actions regarding where the practice needs to be 3 or 5 years from now, and what key capabilities will be required to get there. As part of developing this plan, the practice really needs to identify the key strengths and assets it brings to the table for patients, payers, as well as potential partners such as hospitals, and how it can leverage those strengths and assets in areas such as developing clinical service lines. Similarly, the practice needs to identify the gaps of where the practice is now versus where the practice, regarding key expertise and assets, where it needs to be in the future and how it plans to bridge those gaps, especially regarding the critical area of information technology. The practice also needs to proactively identify the key partners it can work with to bridge gaps to the future. For example, what partners will the practice turn to for expertise and capabilities that the practice doesn't have internally? In addition, how can the practice provide critical new value to payers and hospitals, which in turn provides better quality of care for a lower price to patients? Key opportunities in this regard are clinical service lines, improved patient engagement, compliance and coordination of care, and also better management of specific populations of patients with resources and clinical pathways designed especially for their needs. The next slide points out the importance of having very good information technology capabilities. Advanced information technology capabilities will be even more critical in the future due to the massive growth of data that needs to be managed and coordination of care relationships that must be synthesized into improved patient outcomes. The essential foundation of information technology capabilities is a very strong practice management software platform and a similarly strong electronic medical record capability. Both of these software platforms need to have very robust reporting capabilities, efficient workflows, and good ease of use, along with good automation and functionality for decision support. Another important information technology capability in the future will be data analytics. In the new healthcare environment, clinical performance and patient outcomes will become tightly linked to financial performance. Payers will pay incentives and extract penalties for unwarranted deviation, in their view, from clinical pathways and standards of care. Thus, the practice will need to have the analytics capabilities to ensure they can prove the quality of care they provide and ensure that payers are correctly and completely meeting their payment obligations. Finally, in order to make good business decisions, the practice will need to have good data analytics and even predictive analytics capabilities for evaluating provider, payer, and key partner performance. The next slide describes 4 key revenue drivers for optimizing financial performance. The first driver, again, is IT capabilities. The reason it's pointed out once more is because it's such an important factor in obtaining optimal revenue. In many ways, the practice's revenue will only be as good as the capabilities, tools, and functionality in the practice management software related to billing and reporting of services. The same thing goes for your electronic medical record. If you use a clunky, antiquated, and unproductive EMR, the physician's productivity will suffer, as will the documentation of services and ability to meet the needs of payers and partners for providing high-quality care at the lowest price. A second key capability is having a very good process for managing payer denials and providing timely and effective accounts receivable follow-up. In many ways, optimizing billing is all about plugging revenue leaks, and a major source of revenue leaks for many practices is not preventing denials or not timely and effectively resolving denials. Similarly, not having consistent, timely, and effective accounts receivable follow-up processes allows money to, in effect, rot away through the accounts receivable aging and write-off process. A third key revenue driver is to plug charge capture leaks and patient eligibility leaks. If charges are rendered but not billed due to ineffective billing reconciliation processes, it's the same thing as throwing money in the wastebasket when you walk out of the patient's room. Also, if you capture the charge, but your staff hasn't determined if they are billing the correct insurance or taking the correct copay through a good insurance verification process, payment for the service will get delayed or may even be lost as a denial or an aging AR write-off. Finally, I strongly recommend that each and every physician and even non-physician provider needs to take real responsibility to become very proficient at accurately and completely coding and documenting your services. I've never seen a payer come back and seek to pay a physician a higher amount when the physician has undercoded a service. However, I have seen many payers come back to recoup money after they do a chart audit if the services are not documented completely and accurately. And payers can also allege fraud and abuse and create compliance problems. So the coding and documentation challenges are even going to get greater as we look into 2015 with ICD-10 starting on October 1st, 2015. So the ICD-10 migration is something that really needs to be on the front and center of physician radars to ensure that they don't take a revenue hit when that change occurs. So now I'll go ahead and turn it back over to Clint.
All right. Thank you very much, Dr. Beyer. Well, as Dr. Beyer pointed out, part of being prepared is technology. So we're going to do a little poll here on your technology. So select one or more of the following. If you just have an EMR or just have a PMS, you have an EMR and a PMS and they're integrated, or you might have an EMR and PMS from two different providers and they might not be integrated. Or if you don't have an EMR or a PMS, go ahead and place your vote. We'll leave it open for about 5 or 10 more seconds. And we will be providing you with a recording of this webinar and an ebook that has some of the charts and graphs that you'll be seeing with explanations. We're going to leave the voting open for about 10 more seconds. About 67% of you had voted. So yeah, just click on the little box there, click submit, and we will get the results. Okay, 3, 2, 1. Okay, we've closed the poll. Let me share it with you all. So there is about 50% of you do have an integrated EMR and PMS, 16% where it's not integrated, and some of you all just have an EMR or a practice management system. So this is where our next presenter, Derek Griffin from AdvancedMD, will be able to share some of their technology answers. We've been working with AdvancedMD for quite a few years. So Derek, you want to speak on the need of the integrated EMR PMS and maybe touch on some of that ICD-10?
Absolutely. Thank you, Clint. Okay, so first of all, the goal of technology is to simplify business processes in your practice. To achieve best-in-class results, it's necessary to use best-in-class tools. And so a unified, integrated solution is absolutely necessary if you want to achieve your best results. So this image shows you what a best-in-class integrated unified solution should look like. So the electronic health records should meet, at this point, meaningful use criteria and be meaningful use 2 certified. It should have an effective patient portal, should incorporate technology such as health watchers and ePrescribe, and also be a simple, easy to use, easy to maintain system. As far as the front office goes, if your front office people are struggling or unable to capture co-pays or outstanding balances at the front desk, there's a good chance that you're losing revenue that could otherwise be captured on every visit. As far as mobility goes, with a cloud solution, you can be just as effective at home or at the hospital, at the surgery center, as you would be in your office. So mobility is very important to make sure that you have the features and functionality that you're used to, no matter where you are. And the last solution is charge capture. A quick, easy, functional charge capture is absolutely necessary not only to get charges in the system, but to get them processed and paid quickly. And AdvancedMD has solutions for all these areas, and especially on the charge capture area, we have a variety of ways to do that, whether it be custom charge slips or direct data entry. And once charges are entered, it's very easy to pass them to a premier partner like a Metagain, where Metagain can then take those charges and work their magic to bring the money back and put it in your bank account as quickly as possible. Go to the next slide. So charge capture is very important, but again, the ability to be mobile and to be able to use devices and technology is really going to simplify your practice and the way you do business moving forward. With a cloud system that has applications and easy-to-use features and functions, you'll absolutely be able to take out the inefficiencies that are sometimes experienced when you leave the office. Let me go to the next slide. And then one of the things that was mentioned and should be on everyone's radar is ICD-10. ICD-10 is going to be a very big, very could be effective change. With ICD-10 coming up, AdvancedMD has many tools in place, one of which is this website, which is out on the internet and an area where you can go in and really benchmark yourself and make sure that you're taking the appropriate steps to be ready come ICD-10 go live time. So as you're aware, ICD-10, much like 5010, is going to be not just a technology on the provider side issue, but also a technology on the payer side issue. And with the AdvancedMD technology, we're not only going to help you map from the ICD-9 code to the ICD-10 code where you should be and what you should be coding for, but we're also going to be monitoring payers. And we will let our users know when they're using a payer, if the payer is accepting ICD-9 or ICD-10 codes, and be able to notify you of that before the claim is sent, so that when the claim arrives, it has the absolute best chance of being accepted and paid the first time. At AdvancedMD, we are very committed to building the best-in-class software and maintaining the solution. And we're also very committed to partnering with best-in-class billing companies and services that take it to the next step. And we believe that when you use a best-in-class system with a best-in-class partner like a Metagain, you can absolutely reduce the time it takes you to get a claim out the door while increasing your reimbursement. Thanks, Clint.
Sure. And Derek, one thing I wanted to point out is some of the people don't have an EMR set yet, and your charge capture, which just works right with your practice management system, does help you become ICD compliant because you'll be able to take care of it with just the charge capture app and the practice management system, correct?
Absolutely. Thanks for pointing that out.
Yeah. Okay, so let's go to one more of our polls here. Let's do this about what's real important because it's your money. So how often do you get financial reports? Choose whether it's daily, weekly, monthly, quarterly, yearly. When do you get them, and when do you review them? So as you're keeping track, and especially when we get ready for this time of transition, it's real important to keep an eye on the funds. Make sure you have about 3 to 6 months of backup funds as we get ready to go into this ICD-10 transformation. So about half of you have voted. Just choose about how often you get your financial reports, daily, weekly, monthly, quarterly, or yearly. And also be honest, when do you actually review them? That's what's really important. So we'll keep the voting open for about 10 more seconds. A little over half of you have voted, so let's get a few more of you in there to go ahead and click one of those choices. Click Submit, and 5, 4, 3, 2, 1. Okay, we're closing this poll. Let me share it with you. So the majority of you all are doing it monthly. About 20% of you all daily. That's very good. Weekly, a third, and then the rest of you all are doing it on a wider basis. Okay, so the next person on our parade today is Robert Romero. He's the Vice President of Business Development for Metagain, and he's the one that's going to show you these secret metrics that you can use to help manage the business of your practice. Robert?
Thank you, Clint. So I appreciate everybody joining this afternoon. And from my perspective as a practice management consultant, we really want to focus more and more on reporting and metrics than we ever have before. And at Metagain, through a practice analysis, through our Insights, which is our online kind of live reporting tool connected to the practice management systems like AdvancedMD, and then through our regular monthly reports, there are a large number of metrics that a practice really should be actively involved in reviewing with someone that can help them interpret that on a daily, weekly, and monthly basis. So a few that we're going to look at today, there are 6. And these 6 may be a little bit different way for many of you to look at the data that's somewhat you're already familiar with, but we're going to try to show it in a different light today. Keep in mind that you do need a top-tier practice management system like AdvancedMD and a full-service professional biller to help you kind of run these tests as well as interpret the results. So today we're going to talk about your overall collection rate versus the closed claim collection rate. I'll show you a few examples in how to run these ratios. We're going to look at reimbursement rates by payer and by CPT code, and we're going to look just at closed claims. We're also going to look at a pass-fail test, which is, do you get more or less reimbursement from all your payers than if you just got paid the Medicare allowable? When we look at write-offs, we're going to look at a very specific subset of write-offs that's going to help us determine any root cause or any places in the revenue cycle we need or you need to put some emphasis on to get your maximum reimbursement. And then I'm going to ask you to look at accounts receivable in a little bit different light than maybe you've done it before. Days in AR is a good test, it's a good standard, but in my view it's a little dated, it's a little too easily manipulated, and I think rollover and possible loss are 2 areas that make a whole lot more financial sense to everybody today, if you know how to look at it. We're also going to look at a good matrix of CPTs and payers, which I think everyone should also be reviewing monthly. So let's talk about the overall collection rate and the closed claim collection rate. These numbers are going to come from just the basic reports that you can pull out of your system without too much difficulty. The overall collection rate is a very, very simple ratio. It's all the money you got in associated with all the charges. And it's including write-offs, it's including AR. Many of you know it in your heart, it's 33% or it's 42%, depending on the markup of your charges. So that number is a base number, but we're going to compare that against a number that's a little bit more specific. And this is going to be the closed claim reimbursement rate. So of all the monies that came in a certain period, be it a month or a quarter, we want to do the same ratio, except we want to put it over just those associated claims. So all the monies that came in over just those associated claims. So this ratio won't have any AR and it won't have any write-offs. Your closed claim ratio, the money I got in on all these charges and then those base charges, should be an average of your best claims versus your overall ratio, which is just the ratio of all of your claims. And the question that we ask everybody is, what if all of your claims came in as good as the average of your best claims? The differential between the two is your target for improvement. And if you kind of glance down at the bottom right-hand corner of the page that's on the screen, this particular practice had a 21.5% overall collection rate, but if we excluded AR and write-offs, and we just looked at their closed claim collection rate of 27%, that's the average of their best claims, and the difference between the two is about $60,000. So that would be the top target for improvement. Now, the same exercise of running these numbers also can show you other items, like your payment per visit, also another great metric. If you look at the bottom line, maybe just across this, the top part of the graph, you can see per month, by date of service, the average payment per visit. And yes, your payers are not paying you as much as they ever did before. However, the decline in this particular practice, this analysis, with the same number of visits and the same number of charges, means that there's definitely some improvement that's due just in the last 12 months. So let's take a look at reimbursement ratios now. Let's look at CPT codes first. Please don't look at these on a 100-point scale, and take a peek at the far right-hand kind of green highlighted column. These are going to be just closed claims, okay? So no write-offs, no AR, just the claim that was paid or mostly paid, patient paid or mostly paid, contractual balance was written off, tied up in a bow, we're done. Look at these in groups. Compare like claims to other like claims. The couple that we highlighted, which is easy to see because everybody's got these same codes, is your 99213 and your 99214. So one has a reimbursement ratio of 74%, the other 80%. Is it a documentation differential? What is it that's making one of those codes reimburse better than the other? Is there a request for medical necessity that's coming back to the practice being answered and being answered timely? Pick another subset of your own claims, a typical procedure that's very similar to another procedure. You can look at this by provider as well and see who's getting more money in for their claims than the other. But it's a great exercise once a month. Look at these relative to another very similar claim. check out the highs and the lows. Those are the ones you need to pay attention to. Let's look at reimbursement by payer. Same thing. These are closed claims, and we're gonna group like payers. Look at the graph kind of on the bottom left-hand part of the page, and you can see that this particular practice, the top 4 payers are all commercial payers: Blue Cross, United, Aetna, Cigna. Their contracts, if they're like yours, one might be a little bit better than another by a percentage point or 2, but they're going to be pretty similar. This reminds me that, you know, Medicare and Blue Cross have become some of the two pickiest for verifications at place of service, medical documentation of necessity. They may request more medical records, statistically speaking, than the others these days. And I can see it in this particular ratio. Blue Cross might be one of their better contracts, but it has the lowest reimbursement ratio out of all their commercial payers. And that just might be because there's some documentation shortfalls, or there's manpower shortage just answering all the requests for medical records. You can also use Medicare as a benchmark. So in this particular graph, Medicare's 34% reimbursement ratio. They don't pay you a lot, but they do pay you quickly and they do pay you accurately. So it's a good baseline to use. All of your commercial payers, or most of them, should fall a little bit above your Medicare reimbursement ratio because they will pay you more. However, is it really 54% to 34%? Aetna to Medicare? Blue Cross is only 2 percentage points higher? Maybe that contract is a horrible one, or maybe, once again, we have a shortfall. But it's a great exercise to look at once a month, your reimbursement by payer, to know who is paying you the best out of the dollars that you're asking for. And if one of your biggest payers, in this case, is one of your worst reimbursement ratios, then we all know we need to put some focus, effort, and energy into improving our results for, in this case, Blue Cross. The next test we're going to look at is going to be the pass-fail that we talked about. It's your fee schedule comparison test, or in other words, it's your what if I only got paid the Medicare allowable on all of the claims I submitted. If you would assume that you've got enough commercial payers in your mix that you should always get paid above it, then you should always look to pass each one of these individual tests, pass it in groups of like codes, and then pass it overall. So the left-hand highlighted column, this is the average payment per CPT. It's not the contracted amount, it's the average of the dollars that physically got into the bank. Middle column, the Medicare fee alone. That's your Medicare allowable for your region. And on the right-hand side, did you pass or did you fail in that highlighted column? If your payment per CPT was below the Medicare allowable fee in your region, you failed that test. If it was above it, you passed. Did you pass it for a number of clinical claims, but not pass it for a number of procedures or professional surgical claims, or vice versa? That can show you an area of emphasis for documentation, or for follow-up, or for pre-auths. I don't know what it is, but I can tell you, if you fail one of these individually or fail it overall, there's room for improvement, and this will help show you where to put your emphasis. It also, by the way, will show you how many times your charge is billed to Medicare. Remember, a best practice on that far right-hand column is going to be adjust for your region and for your specialty. Maybe 2.5 times your Medicare allowable markup is right for you. Maybe 4 times is. Maybe only 2 times is. But anyone that's close to getting paid near that allowable you might be at risk for underpayment. So make sure you go through the exercise every January, like we do with our clients, to update your fee schedule. Let's take a look at write-offs, which is our next test. Now, we could look at all write-offs, but if we really want to find root cause or where we could go to make improvements, we're going to filter all these write-offs down a couple of times. The first time is that partial write-offs, we're going to set those aside because I only want to look at write-offs where the full charge in total was paid zero and subsequently written off. You're going to get a lot of codes in there that you know you don't get paid on, but it's good documentation, right? So let's filter one more time. Let's filter only the ones that were paid previously in the period by the same provider-payer code combination, and then that same provider-payer code combination was a zero pay and totally written off. If all we had was 10 claims that fit that category, and all the reasons, if we traced them all back, were totally, completely different, that would probably be pretty normal. It's human error here, there, and everywhere. Or it's a payer missing this, that, or something that's excusable. If it's only a couple of % of your overall collections, statistically, that's okay. But if we have piles, either by CPT, which you can see at the top, and this is a measurement of a pretty big practice, by the way, or if we've got piles by a certain payer, these are the things that we should address, because these are zero write-offs, remember, that were paid previously. So you don't want to see Medicare or Blue Cross or any of the main commercial payers right up there at the top of the payer list. Number one, these are going to be your larger payers typically. And number two, if you've got 125 Blue Cross claims that were previously paid in the same scenario before, we need to trace back that little grouping of claims and make sure that it's either totally spread out across a million reasons, or if half of those were for one reason and another quarter of those were for another, that's where we need to address some attention for that particular payer. Same thing with the CPT codes, which are at the top. If you've got a headache CPT code or 2 or 3 or 5, maybe that one's getting more scrutiny than others, or maybe our documentation isn't up to snuff, or maybe it's an older code. Maybe it's a code that really shouldn't be used anymore and it needs to be updated. A good consult with a certified coder of yours or of mine would be the ticket to finding out if any of these codes should or could be addressed. Once again, trace all these back, find the root cause, and address it. That's your room for improvement. So now we're going to look at accounts receivable. The next test, like I mentioned before, days in AR is a good quality test. I just think it's a little dated. And if you'll take a snapshot of your AR by bucket, you know, your accountants call these guys buckets here, your current and 30-day buckets, that's good AR. That's your cash flow forecast for next month. But the 60, 90, 120, 150 plus buckets are where we're going to focus some attention. I'm going to ask you to look at the highlighted green row that's either in the middle or at the bottom of the page. It's just cut up by payer at the top and code at the bottom. Once again, a good exercise to split these out. In this particular case, I'm looking for rollover. From the 30-day bucket to the 60-day bucket, in a good, healthy AR review like this, I'd expect that number to cut in half or more. And then by 90 days, cut in half or more again. And by 120 days, maybe only have 3 or 4% of my overall AR left there. Those are going to be the hard claims, the ones that have been appealed 3 or 4 times. We're having difficulty getting in the money. we're having difficulty for whatever reason, and they just might be the few that don't get paid that we do write off. All right? Remember, the MGMA says a well-run practice or a better-run practice gets 91.5% of their dollars in. They hold a professional services company like Metagain to a little bit higher standard, 95, 96%. If that number is not decreasing sharply between current and 120, then where does the rollover begin? So rollover in my definition is pretty easily shown in the 60, 90, and 120-day bucket grand totals down there. Statistically, it's roughly equal, which means if this snapshot was from June, and I took the same snapshot in July and the same snapshot in August, my 60-day number from June would become my 90-day number in July, and then again my 120-day number in August. That means this part of the AR really isn't being addressed by manpower or by skill or by whatever reason, and it's rolling over to the next bucket in the next period. If you see all your dollars coming in fairly quickly and then your AR static across the board, that's a key symptom of rollover. If we really put the slide rule to it, I would say in this particular case, somewhere between the 45th and maybe 50th day, this practice has gotten all their money in, and if they haven't gotten it in by that day, they just don't get it in. It rolls over and rolls over and rolls over, and eventually gets written off at 150 days, which is also, in this case, maybe a little aggressive. Itchy trigger finger is my official term for that. Now, look up at the Medicare line, which is the top line. Medicare pays low, but pays fast and accurate, right? So our current bucket, I'm looking to see that money come in next month. But my 30, my 60, 90, 120, and 150 plus is almost static. And since Medicare tends to pay inside of 30 days, my interpretation of this, when you look at the bottom as well, is that this practice is getting one pass at their reimbursement. If that claim went clean and the payment came in, it went in the bank. But rejections, denials, appeals, that process really isn't in place. Secondary claims aren't probably getting submitted either. And a rollover test like this by bucket, once you look at your buckets 1 month and then the next and then the next, or you get it trended for you like in our online insights or our monthly reports, can show you where rollover is happening by payer or at the bottom by code. And this really should be your concern, much, much more than days in AR, which can be too easily manipulated by early write-offs or early adjustments before payments come in, things like that. So let's take a look at one more metric, and that's going to be kind of our bonus here. In our monthly reports, we love to show our clients a metric that has just as much good business information in it as it does billing information. So list your top CPT codes down the left side, and then your average payment per payer across the top. So if you've never seen your practice like this before, it's time to take a look at it like this. Your first instinct might be to compare your average payment to what your contracted amount is per payer per code. Next month, I'll invite you to look at all the highlights. Who's paying you the most? And should we make business decisions based on that? What payer we're going to try to take more of, or what payer we might take less of. Next month, look at it by code. Which codes are paying me more or less, and should I put more emphasis into trying to provide those services for my patient base versus others that may not be so profitable? This is an exercise we go through once a month with our clients, Often we'll notice something get out of balance, or you know at ground level things sometimes better than we do about your contracts and about the history of you getting paid X amount for this particular claim and this particular payer. So oftentimes it's our client also that notices a change in some of these metrics. Remember, Clint, I'm going to steal your marketing line if I'm allowed to, but better metrics really does make better reimbursement and put more money in the bank. It gets you more money faster when you're monitoring these types of tests and metrics in your own practice today. Thanks, everybody. Clint.
Okay. Thank you very much, Robert. We're going to do another quick poll here. So since it's all about the money, how do you obtain your reimbursement? We got 3 choices there. You have an in-house team, you outsource your billing, or you do a combination of in-house and outsourcing. Because as people see their reimbursements continue to decline, and when you look at the fully burdened cost of having a team with salaries, benefits, and everything, it's good to make that comparison between the two. So about 56 have voted, 69. We'll leave the polling open for about 10 more seconds. We will give you a recording of this webinar, and we'll also provide you an ebook that has some of the reports that Robert has been discussing. I'll give you examples, plus a bonus ebook about 6 tips for building a data recovery disaster plan. So we'll go ahead and close the poll. And these are results. About half of you do it in-house, about 16% outsource it, and about a third of you do a combination of having it in-house and also outsourcing it. We're about that time where we're ready for to answer questions. So I will once again show you the team. Dr. Eric Beyer, our Chief Medical Officer, Derek Griffin, the District Manager with Advanced MD, Robert, our VP of Biz Dev, and then myself. So one of the first questions that came in regarded e-prescribe, I guess with the EMR, Derek, because there is a situation here in Texas where they need paper backup for level 2, Schedule 2 and Schedule 3. So how the EMR, since you are nationwide, how do you deal with the different state requirements for EMR or paper?
Great question. So in Advanced MD, when you e-prescribe, when you're e-prescribing a specific medication or drug that can't be sent electronically, the system will notify you and drop it to paper. So we use SureScripts. SureScripts monitors on a state-by-state basis what the rules are, what the regulations are. And so anything and everything that can't be set electronically or faxed will automatically be dropped to a paper script. So you can bring it in as you would normally and have it fulfilled in the office.
Great. And Robert, some of these charts and graphs that you showed, that's part of the practice analysis that Metagain does for potential partners, correct?
Yes, we probably run maybe double the amount that we showed today. But for a practice that's truly looking at working with a full-service billing company, we're happy to do this type of analysis. It takes a couple weeks once we pull data, but it provides you probably information about the practice you've never seen before. And someone that does these every day, myself and one of our lead analysts, to kind of review it with you so you can understand what's inside the numbers.
Well, yeah, like they say, you can't manage what you can't measure. Let's go back to, looks like this question has come up again, Derek, about the charge capture application. So kind of a rule of thumb, how many of the surgeons are actually putting in the charges themselves, or the doctors, or is it somebody on their staff? What do you see out there in the streets?
Sure. It's really case by case. I can't really tell you if there's a more that capture their own charges than don't. But with surgeons specifically, we know that surgeons a lot of times hire transcriptionists to help with their, not only their charges, but the notes behind them. And that's fine, but the quicker we can get charges into the system, obviously the quicker we can get reimbursement into the bank account. So for a surgeon or someone who is comfortable entering their own charges, we can create very quick, simple charge slips where charges can be captured, which, again, quicker charges in, quicker money in. So not a one-size-fits-all for those who are using transcriptionists and third-party coders. That's fine. And these charge slips can be used as also something that the third-party company can use to capture charges on the provider's behalf. So I realize it's not a one-size-fits-all, but the point is the quicker we can get those charges in, the quicker we can get you paid.
And once again, like we pointed out earlier, with that charge capture application, if you don't have an EMR, this can help you get ICD-10 compliant, correct?
Yes.
Robert, part of one question that somebody asked is what kind of process review does Metagain do? I guess it's kind of talking about a front office review?
Okay, so there's actually more than one. So with every new client we bring on, it helps us get to know them and them us quite a bit, is a kind of a front office or front desk process review. Everyone needs to make sure that their policies and procedures that they think they have in place up front really are, and it's pretty good for a third party to help them with that. We also do kind of a coding summary review. We'll go in, recode maybe 10 past procedures or encounters per provider, and have a certified coder do that, present them with any differences, any lost revenue, any coding changes or coding updates that might be recommended. And typically our coding manager or even Dr. Beyer will review that with them one-on-one. And a quick credentialing and quick EOB review as well, just to make sure that when we start to work with somebody, we've got a pretty complete picture of their practice, and any area that needs to be addressed, we know it up front, so that we can do our job as kind of a professional group.
Well, I'm glad you pointed that out, because not too many people have a chief medical officer like Dr. Beyer, who has been an emergency room physician and MBA, started his own company, coding, etc. Well, that's about it. Leaving it open for questions one more time around. Go to the link at the top there if you want to have a complimentary two-year practice analysis where we go in and pull up all these charts that you saw plus additional ones. Look for an email tomorrow from me where I will be providing you a link to the webinar. I'll get you an ebook on the metrics covered during this webinar, plus that ebook on the 6 tips to build a data recovery disaster plan. So I would like to thank Dr. Beyer, Derek, and Robert for leading the webinar today. I'd like to thank all of you for tuning in, and we will let you know when the next webinars are coming up. We'll have quite a few as we get ready for ICD-10 next October. Thank you all very much. Bye-bye.